respected senior professionals and dear friends. India is facing right now, because of the very high numbers of the diabetics and hypertension in the society, so that is chronic kidney disease. In the next few minutes, I would like to talk on CKD and the diabetes, the high prevalence. 1 in every 2 individuals visiting primary care will have the CKD. Diabetes significantly increases the risk of the CKD. Up to 40% of the CKD cases are attributed to the diabetes, and the remaining cases mostly to the hypertension. And a combination of the diabetes and hypertension, a deadly duo, is the important reasons to cause the CKD in Indian population. Kidney disease is a pivotal indicator of the cardiovascular risk in the diabetes. So most of the kidney disease people, they die in the hands of the cardiologist rather than a nephrologist. They don't live till they reach the stage 4 or the stage 5. Most of the people with the stage 3, they will be presented with acute atherosclerotic coronary syndromes. Diabetes exacerbates the outcomes at all stages of the CKD. So the more the hospital stay, more the complications and etc. And it worsens the cardiovascular outcomes, dialysis survival and post-transplant survival. Early detection and proper treatment measures can slow or halt the progression of CKD in individuals with the diabetes. So the need of the hour is, we have to early detection of the CKD is very important, and of course the proper treatment. So not only your ACE inhibitors or ARBs and other drugs, so I will tell you at a later time. See, the kidney disease in the diabetes is a silent killer. So what we see is only the tip of the iceberg. So the lot of the people in the society, they are living with the CKD without knowing that they are living with the CKD, because the common symptom of the CKD is no symptom at all. So no signs of the symptoms until more than 70% of the kidney function is lost. As I told you that CVD risk equivalent is very, very high. Serum creatinine rises only if the 50% of the renal function is already lost. So as long as they lost the 50% of the kidney function, your creatinine levels may be normal. So sometimes now we have to give much importance to the albuminuria also along with the creatinine. 50% of the beta cell function may be lost diagnosed in the type 2 diabetes. So hypoglycemia worsens the kidney impairment. Most of the CKD population, they present with the hypoglycemia rather than the hyperglycemia in our clinical practice. So this is the kidney disease, a slow progressive disease. A lot of the people will be asymptomatic till they get in the stage 4 and the 5. So first they will have the stage 1. So your GFR will be more than 90. In stage 2, it is about 60 to 90. Stage 3, it's again divided into A and the B. 30 to 45 is the B and 45 to 60 is the A. And then the less than 15 to 30 is your 4th stage, and less than the 15, otherwise called as the ESRD, is the stage 5 where renal replacement therapy is the answer, either the peritoneal dialysis or hemodialysis or transplant. So this is a very important heat map showing you, on one hand you have the GFR, on the other hand you have the albuminuria. So as I told you that these two are the very important indicators of chronic kidney disease. So if you see the albuminuria A1, so there is a normal albuminuria, that means less than the 30 milligrams per gram, whereas moderately increased, otherwise called as the microalbuminuria, it is about 30 to 300, and more than the 300 is proteinuria or the macroproteinuria, etc., or macroalbuminuria, etc. And you see here, so the orange or the red, so they are very, very high risk individuals. Even with your GFR of 45 to 59, that means the 3A, but lot of the people will be in the stage 3 or very high risk once their creatinine level, once their albuminuria level is more than the 300. So the more than the 300 albuminuria or 30 to 300 albuminuria, we have to give a lot of respect in spite of the normal creatinine levels. So the take home point here is the microalbuminuria is a known risk factor for the progression of the CKD in the diabetic and the hypertensive CKD population. So microalbuminuria is no more a risk factor for your nephropathy, but also a risk factor for your vasculopathy. So this is the common etiologies. The percentage varies from the country to the country. I think in India, as far as CKD is concerned, the diabetes and hypertension scores nearly 80 to 85% of our population, and glomerulonephritis in some individuals, and polycystic kidney disease autosomal dominant in some individuals, and obstruction maybe because of your oncological or maybe your renal stones, etc., and the chronic urinary tract infections, pyelonephritis, etc., also they lead to chronic kidney disease. So the most common cause of the ESRD is the diabetes all over the world. And here we have to get the 3 tests to be done. One is the blood test, the creatinine levels, and one urine test, that is your urinary albumin creatinine ratio, and then the BP checkup. So the BP checkup is very, very important in all the CKD population, because in the presence of the uncontrolled hypertension, so all the complications of the CKD will be multiplied. So we have to keep the blood pressure as close to the normal as possible in all the CKD population. Not your target is not less than 140/90, but your target should be less than 130/85, or even 120/80 is also sufficient, is good in reaching your BP target in all the CKD population. But it is very easy to say, but very, very difficult to reach your target, because CKD population hypertension is mostly the resistant hypertension. You need 3 molecules, you need 4 molecules, sometimes you have to use the 5 to 6 molecules also to keep your blood pressure around the target of your 120/80 or 130/85. After using your nifedipine 20 milligrams TID or your prazosin, that is your alpha blocker, maybe 2.5 mg starting dose, and 5 milligrams TID and arcamin, and also your loop diuretics, etc. So still the blood pressure will be more than 150/100 in most of the CKD population. So the BP is very, very important parameter in all the CKD population to give them a good quality of the life. So how to screen? So not only your creatinine levels, but also your albumin creatinine ratio. So what defines the CKD diagnosis? Now the CKD diagnosis is not only your GFR less than 60, but albumin creatinine ratio more than the 30. That means microalbuminuria. Either microalbuminuria or the CKD GFR less than 60 for more than the 6 weeks or the 6 months is considered as the CKD definition. Who and when to screen in diabetic insipidus? Type 1 diabetes, you can wait up to the 5 years, because type 1 diabetes is an acute presentation. So they present with polyuria, polyphagia, polydipsia with unintentional weight loss, and all the type 1 diabetes will be diagnosed within no time. So it is a very common that type 1 diabetes people will not have any diabetic related complications at the time of the diagnosis. Whereas the type 2 diabetes, as a part and parcel of your metabolic syndrome, it is a silent disease, asymptomatic. So a lot of the people with the type 2 diabetes in India, they present with the complications even at the presentation of your diagnosis. Renal disease is associated with the increased all-cause mortality. Mortality is more frequent in type 2 diabetic patients with the kidney disease than in those without the diabetes. So the type 2 diabetes with albuminuria or the creatinine levels, so definitely the mortality will be very high. So as I told you that the diabetic etiopathogenesis, diabetic kidney disease, the history of the diabetes or proteinuria, retinopathy. So the kidney and the retina are very, very close friends. So once the fellow is the diabetic kidney disease, should be screened for the retinopathy and vice versa. Hypertension is very, very important. Non-diabetic glomerular disease like nephritis and nephrotic presentations. Cystic kidney disease like urinary tract symptoms, abnormal urinary sediment, radiological imaging abnormal, so multiple cysts, that is polycystic kidney disease. And most important is the tubulointerstitial disease. So the diabetic disease is not only your glomerular abnormalities, but also tubular abnormalities and interstitial abnormalities. So with the history of the chronic urinary tract infections and reflux, especially in the children, chronic medications, your NSAIDs, etc., and the drug exposure, your aminoglycosides, the abnormalities in the urinary tract imaging, your abnormalities in your structural abnormalities in the kidney like Stargardt or caliculi, etc., and tubular syndromes including the urine concentrating defect and abnormal urine analysis. Chronic versus the acute renal failure pathogenesis. Acute because of your tubular cell death and the regeneration, it's mostly the reversible with 1 or 2 shots of your hemodialysis. Most of these people, acute renal failure, acute kidney injury, they recover. But the chronic kidney failure, there will be irreversible nephron loss and they need a permanent hemodialysis or peritoneal dialysis or transplant at a later time. Glomerular hyperfiltration, so it's a compensatory mechanism with increased nephron GFR and predisposition to the glomerular sclerosis. If you see the kidney after the death of the CKD population, the kidney size will be very, very small, contracted, and there will be no differentiation between the cortex and the medulla. So there are the clinical manifestations, your sodium and water retention, pedal edema, puffiness of the face, ascites, elevated JVP, etc. And most of the people will be having the hyperkalemia, So this is the very important. The potassium levels will be more than 5.5, 6, 7, 8 with your classical ECG changes. And metabolic acidosis is the very common. So whenever a fellow presents with the breathlessness in the presence of the CKD, if you examine the lungs are very clear. So the normal lung sounds in the presence of severe tachypnea, tachycardia, please think of the metabolic acidosis and get the urine ketone bodies, that will be the positive, the blood sugar will be 500 etc. and the creatinine level may be 6 or 8 or the 10 and the potassium levels will be 7 or 8 or the 9. So this is the metabolic acidosis. Mineral and the bone metabolism is also very common because the disordered your calcium metabolism and vitamin D3, and also there will be renal osteodystrophy. Cardiovascular pulmonary disorders, as I told you that cardiovascular is very, very common in the CKD population, not only your ischemic heart disease, but also pericardial effusion. You can hear the beautiful pericardial rub in the presence of the CKD in these population, and there will be the pulmonary disorders, maybe the pleural effusions, etc. and sometimes maybe the pulmonary arterial hypertension, interstitial lung diseases are also very common. Hematological abnormalities like anemia, so neuromuscular abnormalities, gastrointestinal abnormalities, etc. So as I told you that the sodium and the water retention, the presence of the heart failure, hypertension, heart disease, ascites, edema, enhanced sensitivity to the extra-renal sodium and the water loss in the presence of vomiting, diarrhea, fever, and chills and dry gut, sweatings, dry mouth, dizziness, tachycardia, tachypnea, and avoid the excess salt and the water. This is the very, very important. Salt and water balance in a diabetic, in a CKD population is very, very important. So the water intake should be about 100 to 500 ml plus the last 24 hours urine output. So one should respect the urine output in all the CKD population. Suppose the Saturday he is passing about 1 liter urine. So next day, the Sunday, his input must be somewhere between 1200 to 1300 ml. So that is the very important in the CKD population. Suppose if he takes the more and more water, he will present with acute pulmonary edema and he needs an admission. So whatever the water intake must be based on the previous day's urine output. That is a very, very fundamental point in CKD population. Of course, more the salt, more the water absorption, and again more and more acute pulmonary edema. So salt restriction and water restriction is very, very important in the management of the CKD population. Diuretics are also important, not your chlorothalidone or hydrochlorothiazide in the established CKD. You should go for the loop diuretics like your Lasix or the torsemide once the GFR is less than 30. And of course, dialysis once their creatinine levels are more and your GFR is less than 15%. Hyperkalemia is very, very important. So the GFR more than the 5 ml per the minute compensate aldosterone mediated potassium transport, and potassium sparing diuretics are very, very important to be used here with a caution. Once the fellows are the ACE inhibitors or ARBs, so there is a tendency to have the hyperkalemia, and once you use the potassium sparing diuretics like your spironolactone, definitely there will be the hyperkalemia chances there. Metabolic acidosis already told you. Mineral density is also there, decreased calcium absorption from the gut. So all the CKD population, you should administer the calcium. It's a very, very important. And the overproduction of the PTH, this is also very important. And here you have to use the terpenade, etc. Some injections are there. So you have to use to reduce the overproduction of the PTH. And altered vitamin D metabolism, so you have to give the 60,000 once in a week for about 8 to 12 weeks and then once in a month. And the chronic metabolic acidosis has to be treated. So there is the decreased renal function, there will be the hyperphosphatemia and the reduced vitamin D3 and accumulation of the B2 microalbumin. So it all will lead to the metabolic acidosis and the excess calcium and vitamin D, peritoneal dialysis, etc. Some cardiovascular and pulmonary abnormalities, already we discussed heart failure and the pulmonary edema, hypertension, hyperrenemia. So that also will lead to the hypertension because of your RAS overactivity. So there will be more and more production of your angiotensin II, which is a potent vasoconstrictor, definitely will lead to the more hypertension. And already pericarditis, I told you, pericardial rub and etc. And atherosclerotic acceleration, and you will have the link to the factors above and the metabolic abnormalities. Hematological anemia, not because of your iron deficiency or vitamin B12 deficiency, but here the anemia is more because of your erythropoietin deficiency. So all the CKD population, established CKD population, so you should give the erythropoietin in the strength of about 4,000 or 6,000, 8,000, 10,000 units, maybe once in a week or twice in a week, so to tackle the anemia. Because presence of severe anemia in the CKD population, you are inviting more infections like your tuberculosis or pneumonias, etc. And also the precipitation of the heart failure is also very common in the presence of the anemia. So anemia has to be corrected with your erythropoietin. Bone marrow suppression because of uremic toxins, so they cause leukocyte suppression, and obviously they will lead to more and more infections. Bone marrow fibrosis and increased bruising, blood loss and hemorrhage, and of course the prolonged bleeding time and abnormal platelet aggregation. So these are all the bleeding tendencies, clotting tendencies, etc. also will be there in the CKD population. Neuromuscular abnormalities like sleep disorders are very, very common. So your dipping and non-dipping, one has to get the normal blood pressure of 120/70 during the sleep, not possible in the CKD population. Even during the sleep also, their blood pressure will be 140/90 or 150/100. So that shows early morning atherosclerosis and the vascular events are very common in our CKD population because of the sleep disorders. Impaired concentration, memory, irritability, so these are very common in these individuals, and they will sometimes they present with the tremors, myoclonus, osteoporosis, and maybe the CKD induced seizures, and finally uremia and also coma. And restless leg syndrome, so they are very irritable, and hemodialysis related neuropathies, so they are the neuromuscular abnormalities. Gastrointestinal peptic ulcer disease are very common. Uremic gastroenteritis, so there will be the mucosal alterations, bad breath, there is ammonia breath, uremic fetor when the creatinine level is very, very high, and non-specific abnormalities like anorexia, nausea, vomiting, hiccups, diverticulosis. So these are all very common in our people with established CKD with creatinine levels more than 10 or 11. Endocrine abnormalities, the insulin, the prolonged half-life due to the reduced clearance, the reduced metabolism, amenorrhea and the pregnancy failure because of the low estrogen levels, impotence, oligospermia and germinal cell dysplasia because of the low testosterone levels. Dermatological, the skin is very paler because of the anemia. Skin color is also changes, accumulation of the pigments, there will be having the depigmentation, and there will be the blackness of the skin, and these are all this very common in the CKD population, and itching is very, very common here. Ecchymosis and hematomas because of the clotting abnormalities. Pruritus is very, very common in the CKD population. Whatever the tons of the anti-allergics you prescribe, so it's very, very few people will get the good response in spite of your lot of the drugs. So these are all because of your calcium deposits from the secondary hyperparathyroidism. So concentrate on the afferent arteriole and the efferent arteriole. The first one is the normal, and the second one you see the afferent arteriole is very much dilated, whereas the efferent arteriole is very much constricted. So here there will be the intraglomerular hypertension, intraglomerular hyperfiltration, there will be changes in the glomerular basement membrane, there may be changes in the proximal tubule, so all will lead to more and more renal death. So angiotensin II, so vasoconstrictor, cell growth, proliferation, hypertrophy, PAIN1 expression, aldosterone release, so these are all very common with angiotensin II, which is not a good for our humans. So that is the reason we use the drugs which reduces your angiotensin II, like your ARBs and ACE inhibitors. I think this is the best slide of today's talk. The measurement of the blood pressure is likely the clinical procedure of greatest importance. So just measurement of the BP is one of the greatest importance that is performed in the slopiest manner. So this is the very important because the BP is very important in all the CKD population. So antihypertensive medications we have to use very aggressively. Now the CKD therapeutic landscape. So see the 1990 to 2005, the foundation era. We have the only few drugs like the trials like the captopril trial, IED trial, renal trial, etc. So the ACE inhibitors and ARBs, they reduce the proteinuria and slow the CKD progression, especially in the DKD. So for almost 20 years, RAS blockade was the only proven therapy for the kidney. In 2005 to 2014, no major breakthroughs. 15 to 22, the expanded benefits to the non-diabetic CKD, SGLT inhibitors, they are the game changers. We all know the importance of the SGLT inhibitors in the management of your CKD, in the management of your diabetes, in the management of your heart failure. So these are the different trials are there. So DAPA CKD and EMPA CKD, etc. Fidelio DKD and Figaro DKD, this is on the Finerenone. So this also we had a a separate CME last year. So finerenone is a non-steroidal mineralocorticoid receptor antagonist, unlike your spironolactone. So spironolactone will impair your hormones, sex hormones. They cause the gynecomastia, whereas the finerenone is not having that effect. So no gynecomastia with the finerenone. It is available in the two strengths. One is 10 mg and the second one is the 20 milligrams. 10 mg for those people with the GFR less than 25 and 20 mg with the people with the GFR more than 25. Last 2 to 3 years, we had semaglutide. So we have the oral semaglutide, Rybelsus, and now we have the injectable semaglutide, that is the Wegovy. So available 0.25 mg and 0.5 mg, 0.75 mg, 1 mg, etc. So the different drugs are coming up. Now the GLP-1 receptor agonists are very, very important drugs to be used in most of our CKD individuals. So what are the treatment modalities? So I told you something about the fluid balance, as low as possible, and protein. So the decreased protein is not right for our Indians. So this is the Western slide. They say that they take a lot of the protein, maybe 1.5 to 2 grams a day, but we Indians, we take just 0.6 to 0.7 grams per day. So that is the reason. So even though our people are in the CKD, don't reduce the protein content. So the protein has to be given at least 1 gram per kg body weight. So decrease the sodium, that is a very, very important. We all use sodium to the tune of about 8 to 10 grams, but just 2 grams is sufficient. So that is a very, very important take home point. And decrease the potassium, rich with the coconut water and more with the fruits. So these two has to be avoided in the CKD population because they contain a lot of potassium. And decrease the phosphorus, dialysis is very important, and RBC and vitamin D transplantations. So you all know that is the deadly quartet: diabetes, hypertension, heart and the kidney. So a lot of the control, diabetes control is very important, BP control is very important, vascular control with your aspirin, clopidogrel, etc. And lipid control is also very, very important, either with the statins and the fibrates. But a word of caution is, when you combine the statins and the fibrates, there may be a tendency of elevation of your creatine levels. So in established CKD population, we don't want to use add the fibrates. Instead of that, we use the statins, or we can use the ezetimibe in the established CKD population. Otherwise, you can add the bambodoic acid that is also available right now in the dose of 180 milligrams. So that also reduces the cholesterol synthesis, almost like the statins, but that is not having a side effect of your myalgia or rhabdomyolysis. So those people with the myalgia and rhabdomyolysis, the statin therapy or statin intolerant, you can try with the bambodoic acid. Lifestyles are very, very important. So the glycemic control, BP control, vascular control, lipid control are very, very important. So the monitoring, you all know that your albuminuria, your creatine elevations, etc. Anemia and the role of the erythropoietin already discussed. Electrolytes, minerals and bone abnormalities, this is also very important. Diet in CKD is very, very important. Choose and prepare the foods with less salt and less sodium. Right types of the protein, so right diet, right people, right time. Healthy for your heart, etc. Limit the protein, increase the protein. Less phosphorus, right amount of the potassium. Modify your diets to restrict the potassium and the phosphorus intake for the kidney protection. Exercise is also very, very important. Staying fit with the kidney disease. Benefits of the exercise: improves the muscle physical functioning, better blood pressure control, improved muscle strength, lowered the levels of the fats, the cholesterol will come down. Better sleep, that is very, very important with the exercise. The sleep will improve, right? And better control of the body weight if you are overweight or the obese. So the important drugs to be used. A word of caution is the metformin. Earlier we thought that metformin has to be stopped in all the CKD population. So once the creatine level is say more than 1.5 or the 2, and if you see the GFR less than 30, so better to stop the metformin. So there we use it the two words. We use it to remember 30 and the 60. When the GFR is more than the 60, you can use the usual dose of the metformin. When the GFR less than the 30, stop using the metformin. Between 30 and 60, use the half dose of the metformin. So that was the old saying. Right now, even with the GFR of less than 30, some amount of the metformin usage is always ideal in the CKD population. Maybe 250 mg or maybe 500 mg, not more than that, even in the established CKD stage 4 or the 5. SGLT inhibitors, excellent drugs. Now all the cardiologists and nephrologists, they are using SGLT inhibitors even in the non-diabetic individuals because of their positive effects. And the gliptins, already I told you the DP4 inhibitors, you can use the lenagliptin without any dose adjustment. But on the other hand, you can also use all other gliptins also with the dose adjustments. But don't use the teneligliptin and the saxagliptin because they cause more and more cardiac abnormalities and heart failure. Sulfurides usually we avoid except the glipizide, which is the shortest acting sulfonylurea. So in Vardhanam area, so the people are very poor, so they can't afford the insulin or the other drugs. Then they use the glipizide, your glycinase, MF, etc. GLP-1 receptor agonists are very, very important drugs, and insulin. So once the sugars are very high, but most of the people with the CKD, established CKD, their sugars will be under good control even with a few drugs, and most of the people they present with hypoglycemia also. So the lifestyle, healthy diet, physical activity, cessation of the smoking is very important, weight management is very important. First line drugs, your SGLT inhibitors, your metformin, your RAS inhibitors, and moderate or high intensity statins. And then you can go for the GLP-1 receptor agonists and your finerenone, your dihydropyridine calcium channel blockers like your amlodipine and cilindipine, and antiplatelet agents, either your aspirin or the clopidogrel, and ezetimibe, PCSK9 inhibitors when the cholesterols are very high and present with acute coronary syndrome with high thrombins, etc. So these are the important drugs to be used in all the diabetic individuals. Okay, this is a very good slide, shows you commonly prescribed drugs that may need to be reduced in the dose or seized in the CKD. These are the drugs to be reduced in its dose, like your acarbose. See, acarbose, even though they act only at the level of the intestines, but most of the CKD population, they present with nausea, vomiting, abdominal cramps, etc. If you use the acarbose, obviously their gastrointestinal symptoms will increase. Apixaban, so after our COVID, so use a lot of the apixaban, dapigrotine, etc. Exenatide we are not using at all. Gabapentin has to be used with a caution in the CKD population because they have the giddiness, they have the pedal edema, and also some hypotension, etc. Glimepiride, long-acting OHS, especially with glibenclamide and the glimepiride, has to be stopped in the established CKD and use the shortest acting sulfonylurea like glipizide. And the lithium, so nowadays most of the, even the psychiatrists also not using the lithium. Here our psychiatrist is here, Ramchandra Rao, he is not come. Saxagliptin has to be stopped for the fear of heart failure, spironolactone because for the fear of hyperkalemia, vildagliptin, usual in the heart, in the hepatic failure we don't use the vildagliptin. Even in the renal failure also we have to reduce the dose of the allopurinol we use in the gouty arthritis, benzodiazepines and digoxin. So these are the simple important drugs, antivirals, colchicine, fenofibrate, I told you about the fenofibrate dose, and steroids, yes. So they are the important drugs has to be reduced in its doses. So you have the mineral spironolactone, eplerenone, and finerenone. These also I told you. So relationship of the cardiovascular disease and the CKD. Traditional risk factors. You all know the vascular risk factors like your age, elderly, obesity, tobacco usage, strong family history, hypertension, diabetes, etc. And significant risk factors, the toxic metabolites in the uremia, albuminuria in CKD, vascular inflammation in CKD, oxidative stress in CKD, endothelial dysfunction, anemia, malnutrition. So all will lead to cardiomyopathy, atherosclerosis, arterial stiffness, and arterial calcification. Your calcium score will be more than 400, 600, 1000 in the CKD, established CKD population. So they are present with ischemic heart disease, heart failure, renal progression, cardiovascular death, and cerebrovascular disease. Hypoglycemia will affect the heart in two ways. One, it increases the ischemia and infarct. On the other hand, they precipitate the arrhythmias and ectopics. So reducing the risk of the cardiovascular disease. So these are the risk factors: hypertension, prothrombotic state, dysregulation of the lipid metabolism, increased oxidative stress, hyperphosphatemia, etc. So the diabetic nephropathy, you can't stop it. So you can't cure it. So you have to endure it. So you should know how to manage the diabetic nephropathy and how to live with the diabetic nephropathy. So less than 2% of the patients with the DRD, the diabetic kidney disease or diabetic renal disease, they require the RRT, that the renal replacement therapy, because others often die of CVD before they reaching the ESRD. That point I already told you. So the dialysis get an early vascular access for the HD. Once the creatinine level is more than 4 or the 5, it's better to go for the AV fistula. So the AV fistula is very, very important in all the CKD population for an emergency hemodialysis. So peritoneal dialysis to patients with adequate manual dexterity, insulin therapy offer. So these are the very important advantages of the PD over the hemodialysis. So peritoneal dialysis advantages, so less complicated, it's the portable, fewer dietary restrictions, shorter training time, etc. And the hemodialysis advantages, rapid fluid removal, this is much more superior than the peritoneal dialysis, and the risk of your peritonitis is less with the hemodialysis. But hemodialysis, they need a center, they need a mission, they need a technicians, etc. Whereas the peritoneal dialysis can be done by yourself. So this is the disequilibrium syndrome, especially with your hemodialysis and peritoneal dialysis. And transplant is a very common answer for living and the cadaveric donors. And pre-dialysis and dialysis may increase the acute tubular necrosis, immunotherapy, etc. Complications, resections, either acute resection or the chronic resection. Not only the resections, the infections are very common in the post-transplant, hypertension, post-transplant hypertension, some malignancies, especially the lip and the skin and lymphomas and cervicals, recurrence of the renal disease, again the recurrence of the disease in the post-transplant kidney, retroperitoneal bleed, arterial stenosis, and urine leakage. So comprehensive well-being is very important, holistic approach, lifestyle and nutrition is very important, emotional health is also very important, symptom management, quality of the life, personalized care, resilience, and beyond the medical. So now the role of the NAC tarin and the pyridoxamine in reducing your serum creatinine and the macroalbuminuria. Today's sponsors, the Force India. So an approach to save the nephrons in the diabetes and hypertensive patients. See, the 9 to 43% there is a residual risk remains despite the available treatment options. Now we have the lot of the options like your ACE inhibitors, ARBs, your pheneranone, your GLP-1 receptor agonists, SGLT inhibitors, etc. But still there is a residual risk. So it's all because of the imbalance in the residual oxygen stress and the antioxidant leads. Residual oxygen species and antioxidants. So this leads to the more and more tissue injury, more and more vascular inflammation and apoptosis leads to the damage. N-acetylcysteine and the kidney, it is a direct scavenger of the free radicals, N-acetylcysteine. It is an antioxidant, has been reported to protect the kidney from injury induced by the contrast media, ischemia and the toxins. It can also lower the albuminuria. It improves the kidney function, relieves the inflammation and reduces the cardiovascular events among the people with the CKD. So these are all the advantages of using N-acetylcysteine. So this is the European journal, retrospective study says that progression to the end-stage renal disease will be halted or will be reduced, will be with the addition of N-acetylcysteine. So this could be used to reduce the CKD progression to the end-stage kidney disease. This is a very important point because reaching an ESRD very fast in all the CKD population, that means we are inviting lot of the infections and the quality of the life will be very much reduced. So the taurine and the kidney, so the taurine will help you in the renal blood flow, it regulates the renal blood flow and reduces your ischemia and the perfusion injury, and also it has an antioxidant properties. So these are all the advantages of the taurine, like your N-acetylcysteine. So N-acetylcysteine and the taurine will give you a protection from this reactive oxygen species to damage the kidney and to damage the glomeruli, to damage the fibrosis and etc. So the NAC and taurine, an evidence-based approach in reducing the microalbuminuria, in the diabetic study, nephro study, etc. So there are a lot of the centers, all they say that study 1, result treatment group, urinary albumin creatinine ratio will be reduced, no such significant changes were noted in the control group. In the study 2, it's a Kidney International reports, they say that prospective multi-center study. So a lot of the nephrologists, so from the north, south, west and etc. they were involved with good institutes like Sir Gangaram Institute from Hyderabad, from Delhi. So they say that the NAC and the taurine shows the improvement in the 3 parameters. So what are the 3 parameters? Microalbuminuria reduction, serum creatinine reduction, and cystatin C reduction. So by reducing these three parameters, definitely you can halt the progression of the CKD. So the results, the overall urinary albumin creatinine ratio declined by 18% in the NAC plus taurine group, and there will be 34% reduction in the microalbuminuria and nearly 18% reduction in the macroalbuminuria in these groups. So again the cystatin reduced by about 22%. So the NAC and the taurine with the low protein diet helped in the preservation of the GFR after the 6 months of the treatment. So once you are preserving the GFR, once you are making the creatinine at the same level, so obviously we are improving the quality of the life and also we are avoiding the complications of the CKD. So in summary, nearly 18.6% overall reduction in the urinary albumin creatinine ratio, nearly 34% reduction in the microalbuminuria, and cystatin C reduced by nearly 22% with this group. So this study, Diabetic Center, nearly a good study, important studies from Chennai. So our teacher Mohan from Mohan Diabetic Center, he also said that a retrospective study shows that mean urinary albumin creatinine ratio reduction is a very, very good here. So in summary, as per the studies, the NAC and the taurine can be considered as adjuvant in patients with the microalbuminuria. So all the people with the CKD, you can safely use them. So the NAC and the taurine benefits are better in the diabetic patients with the microalbuminuria. So this is the cardiology study. A lot of the people are here involved, even from Hyderabad Nizam's Institute. So they also say that the creatinine, the GFR reduction is very much halted with this therapy. So the mean increase in the GFR was about 8.5 units higher in these individuals. Lot of the studies all over the country. So finally they say that NAC and the taurine, a natriuretic adjuvant to treat the microalbuminuria. These four pillars, you know that, the RAS blockade, SGLT inhibitors, non-steroidal, mineralocorticoid and GLP-1 receptor agonists in the CKD progression. Whereas in the heart failure, so instead of the last fourth pillar, GLP-1 receptor, you can have a ARNI. So managing your diabetes is not only a science, but also an art. Thank you very much.